Ear-based vagus stimulation is one of psychiatry's most interesting investigational neuromodulation questions. So here's the setup. Ear stimulation is being sold like it can calm mood, sharpen focus, and improve sleep. But the real clinical question is sharper than that. It is not whether the ear is some kind of magic treatment target. It is whether stimulating the ear can reliably engage vagal circuits in a way that actually changes psychiatric outcomes. First, do not collapse three different ideas. Implanted VNS means a surgical device stimulating the cervical vagus nerve. Cervical tVNS means non-invasive stimulation over the neck. Auricular a VNS means stimulation at ear regions partly innervated by the auricular branch of the vagus nerve. Those evidence bases are related, but they are not interchangeable. The mechanistic appeal is plausible. Vagal afference project toward the nucleus tractus solitarius, then into systems linked with locus coeruleus norepinephrine signaling, limbic prefrontal regulation, autonomic balance, and inflammatory signaling. That is exactly why psychiatry is watching this space. But plausible circuitry is not the same as a proven treatment. Depression is the bridge from established VNS to taVNS. Implanted VNS has an FD, an indication for adjunctive long-term treatment of chronic or recurrent depression after inadequate response to 4 or more adequate antidepressant treatments. The RECOVER trial adds modern long-term data in markedly resistant MDDT. VNS depression studies exist, but meta-analytic evidence is low to very low quality. Here is the underappreciated signal: cognition. A 2026 meta-analysis found taVNS associated with better cognitive performance, especially executive function and learning. For psychiatry, that matters because cognition cuts across depression, ADHD, schizophrenia, PTSD, and functional recovery. Still, these are domain signals, not a diagnosis-level indication. Other psychiatric adjacent signals are emerging. A small 2025 schizophrenia RCT reported improvement in negative symptoms with taVNS add-on treatment and explored TNF-alpha and EEG coherence biomarkers. Insomnia reviews also suggest active study interest. But these are early symptom domain signals, not proof that taVNS treats schizophrenia, PTSD, anxiety, ADHD, or insomnia. The most important future idea may be timing. In a 2026 Perrin movement study, brief taVNS bursts preferentially enhanced motor circuitry when stimulation was paired with active movement, not simply delivered at rest. That is not a psychiatric trial, but it illustrates the principle. Stimulation may work best when the relevant circuit is already active. Before routine psychiatric adoption, the field has hard problems to solve. Protocol heterogeneity, sham controls that may not be truly blind, stimulation dose, durability, patient selection, biomarkers, and consumer devices making claims well beyond the evidence. A clinic should not treat a wellness headset as equivalent to a studied medical protocol. So the bottom line is cautious but serious. taVNS is not a mainstream psychiatric treatment yet. Its future may be less ear stimulation treats depression and more vagal stimulation plus the right task, state, therapy, or symptom target. That is why it belongs on psychiatry's watch list, not in the hype file. Questions or episode ideas? Drop them below and subscribe for more psychopharmacology breakdowns. Educational purposes only, not a substitute for clinical judgment.